Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Rawee, consultant maxillofacial surgery from Iraq, Nineveh. Have two fellowship from England and Glasgow with PhD from Iraq. Really, it's honor to present this lecture. All thanks and appreciation to the committee for this conference, specifically to Dr. Mazen for such invitation. My lecture will highlight an important subject, which is orthognathic surgery concept, principles, and technique. It's important not only to improve access to oral care, but also improving function and aesthetic, specifically in cases where orthodontic treatment will fail or it will be adjuvant to surgery. The lecture divided into two parts. First part, it's how to evaluate and diagnose the cases. The second part will define different surgeries with case presentation. The lecture will be recorded really to avoid the network issues problem. Starting with the term orthognathic. It comes from the Greek word which is orthos mean straight and gnathos mean jaw. يعني معناها straight jaw. It can be defined as a surgery for treatment and correction of facial disproportion, dentofacial deformities, malocclusion, and associated problems or abnormality of the skeletal component of the face. We know that dentofacial deformities can be congenital or acquired. Malocclusion and associated abnormalities of the skeletal component of the face occur as a result of different conditions like inherited tendencies, prenatal problems, systematic conditions that occur during growth, trauma, and environmental influences. These photos showing different skeletal and malocclusion disproportion. We know that bone growth can be affected when muscle and soft tissue dysfunction exist. Muscle and soft tissue dysfunction including an improper swallow, prolonged thumb and pacifier habits, sucking مثلا, overactive lip and cheek muscles, mouth breathing, resting open mouth posture, and also low tongue posture, large tongue. All these can affect the bone growth. Among the environmental factors involved in the development of malocclusion are deleterious habits, mouth breathing, and trauma. Several genes also play a role in development of facial bone, muscle, and teeth disproportion and with development of malocclusion and the skeletal abnormalities. Treatment objectives include function aesthetic. Function definitely to establish a functional occlusion aiming to achieve normal overbite, overjet, and transverse relationship. The aesthetic is to normalize the facial balance and properties in 3 dimensions, in addition to provide stable result in long term to avoid recurrence of the conditions. Other possible benefits can include temporomandibular joint dysfunction treatment, mouth opening, sleep apnea, and traumatic occlusion. The management protocol for facial deformity should comprise حال أي conditions like history taking, clinical examination, investigation, initial diagnosis to reach the final treatment plan. Either we need pre-surgery surgical orthodontic or post-surgical orthodontics and definitely surgery. The most important steps is to evaluate the existing problem correctly and define the best treatment goals. The patient current health status, psychological and medical problems all should be discussed with the patient at this step before decide any treatment plan. Both maxillofacial surgeon and orthodontists with other specialties if needed all work in consistency to each other through the MDT clinic or committee, which is the multidisciplinary team clinic. Make a thorough examination of facial structure with consideration of frontal and profile aesthetic. Discuss the treatment plan with the patient and to have good result and best patient satisfaction. Clinically, the patient should be assessed in sitting upright position with the Frankfurt plane parallel to the floor in natural head position. Facially, we should evaluate the patient, keeping in mind that we not evaluate single bone alone. We should evaluate the patient as a whole, not looking for deviation from the normal of a single facial unit, but the search for proportion. By increasing vertical dimension, definitely the facial harmony will last. We should increase both transverse and vertical dimension to restore the harmony to normal. Soft tissue can give us an indication for the disproportion skeletally or dentally, so we should keep in our mind some soft tissue parameters to overview the facial aesthetic and the interpretation differentiation of the possible underlying deformities. In a frontal view, the face is divided into three main thirds, starting from the hairline to the chin line. The upper third from the hairline to the bipupillary line. The middle third from the bipupillary line to the nose line. The lower third from the nose line to the chin line. The lower third, it's also subdivided. In case of a presence of gummy smile, the amount, which means the amount of gingival exposure when smiling, and the amount of upper incisal exposure under the upper lip in repose. Ideally, the upper lip vermilion should fall at the cervical gingival margin with no more than 2 mm of gingival exposure during smiling. In this photo, we can see the upper lip position in both in repose and during smiling in gummy smile cases. To analyze the facial width and symmetry, the face can be divided into fifths. The bigonal width, usually approximately 30% less than the bizygomatic dimension. Chin, the width and shape of the chin should be evaluated also, as it forms the harmonious part of overall facial contour. The relationship between height and width of the face has an important influence on the facial form and harmony, so correlation with patient's overall body build also should be evaluated. يعني البرسن اللي هو giant facial bone also it will be giant. The height to width properties are 1.3 to 1. These figures showing the bizygomatic arch dimension and the bigonial arch dimension. Only the difference in other photos showing the difference between male and female relations in bitemporal, bizygomatic and bigonial dimensions. Measurements that give an indication of harmony between the nose, mouth and eyes, including the interpupillary distance. It ranges between 65 plus minus 3 mm, intercanthal distance 32 plus minus 2 mm. Vertical lines which drawn through the medial canthi should coincide with the aloe of the nose. The vertical lines drawn through the medial margin of the iris of the eye should coincide with the corners of the mouth. These measurements can give an indication of harmony. To evaluate the facial symmetry, facial and midline, dental midline should be evaluated. Correction for dental midline, mostly orthodontics. The left to right symmetry must be corrected with the facial midline, and the face should be reasonably symmetric. Keep in mind that no face is perfectly symmetric. When evaluating the symmetry of the face, it's important to assess the presence of any occlusal plane canting. The occlusal plane should be parallel to the interpupillary line. This photo can showing us the deviation from the midline and the occlusal plane canting with the relation with the interpupillary line. In profile view, we have some points should be kept in mind, and looking for the normal convexity of the face, including the nasolabial angle between the columella of the nose and the upper lip. It's the guide to the upper lip support by the maxillary incisors. The lip-chin throat angle, also we should define this angle between the lower border of the chin and the line connecting the lower lip and soft tissue begonian. Acute in a flat or convex profile with a class 3 dentoskeletal pattern as seen in these photos, while obtuse will be in a class 2 malocclusion mandibular anterior posterior deficiency microgenia. Upper lip length should also be evaluated from the subnasally to lower lip, with the difference between male to female ratio should be 20 plus minus 2 mm for female, 22 plus minus 2 mm for male. During the treatment plan, we should keep in mind that upper lip with the age will increase in length. Ricketts analysis has projected a line from the nasal tip to soft tissue begonian and suggested that the upper lip be 4 mm and the lower lip 2 mm behind this line. It's a very useful in planning. The labiomental angle formed by intersection of the lower lip and the chin measured at the soft tissue B point. All these clinical findings should be documented on a specific case sheet added to that standard digital photography, profile, frontal, three-quarter, bird eye view are taken and attached to this case sheet. Dental examination should also include assessment of dental arch form, symmetry, tooth alignment, occlusal abnormalities in the transverse, anterior, posterior, and vertical dimensions. Muscle of the mastication, TM joint function also evaluated. Patient hygiene and current periodontal health status also evaluated. Even psychology of the patient also should be evaluated as well to know what the patient will from the treatment plan. After a clinical examination with digital photography, radiographical evaluation also should be performed. Routine radiographs are lateral and frontal cephalometry, panorama, periapical X-ray if needed. Cephalometry is an plane X-ray taken in the sagittal and frontal plane. Cephalometric analysis can be helpful diagnostic guide. Lateral and frontal cephalometry can be done to evaluate the proportion of the facial skeleton and to compare the individual patient from normal. Standard skeletal analysis is based حقيقة on cephalometry analysis based on reference point lines and angle, which are marked on the X-rays as we see in this frontal cephalometrical analysis. For hard tissue landmarks, we have point line and angles. Points including nasion, orbitali, cilli, anterior nasal spine, and A point, B point, gonion, menton, borion, condylon, gnathion, and glabella. For the lines, we have Frankfurt horizontal plane, anterior cranial base, occlusal plane, mandibular plane extended from the gonion to ME. The author preferred to use the anterior cranial base اللي هي SN as a horizontal reference plane. These figures showing the hard tissue planes and points with the angles. The skeletal anterior-posterior relationships angle. The maxillary anterior-posterior position will be evaluated in relation to the anterior cranial base, about 82 degree for the normal maxilla. The mandibular anterior posterior position, the position of mandible, will be related to the SN, about 80 for a normal 80 degree for a normal mandible. The A and B angle relationship between the upper and lower jaw in class 2 will be increased, while in class 3 will be decreased. Angle of 2 degree indicated a normal relationship. The other evaluation and diagnostic step, which is the model analysis or study cast. The upper and lower cast taken and the centric occlusion recorded in order to evaluate the malocclusion disharmony. The model oriented in a semi-adjustable articulator after face bow transfer. The model allow analyzing the occlusion, shape of dental arch, position, size and shape of teeth, position of the jaw in relation to the skull base. Usually 2 sets of model are used. One is kept to analyze the preoperative situation, the second set used to perform the mock surgery. For the orthodontist rule in orthognathic surgery, the orthodontist can deal with the patient pre-surgically or post-surgically. Pre-surgically, as a consideration, not all malocclusions require correction with surgery. In some cases, with skeletal abnormality, orthodontic compensation will result in adequate occlusion but poor facial aesthetic, which make patient disturbed. These patients considered usually for orthognathic surgeries. In concerning to treatment timing for orthognathic, we know that surgery should be delayed until growth is completed after 18 years old. The objective of pre-surgical orthodontic treatment will include repositioning of the teeth without consideration for the bite relationship to the opposing arch, which can cause accentuation of the patient deformity and giving bad facial harmony. The essential step in orthodontics are to align the arch individually and not in both arch. يعني ما بالضرورة أنه يحقق occlusion بين الماكسيلا والماندبل، وإنما إحنا مجرد alignment للتيث حتى تساعد السيرجن to return the normal occlusion. Final treatment planning should include pre-surgical periodontics treatment, restorative dentistry, also orthodontic treatment. Facial structure, malocclusion, digital photography, radiographs, all re-examined. Model surgery on a duplicated cast determine the exact surgical movement necessary to accomplish the desired post-operative occlusion. According to clinical anti-phallometric analysis, the problem diagnosed and the treatment plan generated, both surgeon and orthodontist should agree on the planned surgery. The mounted model can then be moved in a 3-dimensional fashion into the planned position. Mock surgery is performed to mimic the planned surgical procedure as decided by the maxillofacial surgeon and orthodontist. Finally, the reoriented model after mock surgery are used to fabricate the surgical spline that will be used in the operating room. Individual stereolithographic model also can be used in severe and asymmetric deformities with mock surgery.